Welcome to our introduction to the fundamental principles of physics in anesthesia. When most people think about anesthesia, they think about medications, induction agents, opioids, neuromuscular blockers, and volatile anesthetics. But behind nearly every action performed in anesthesia is physics. Every time we ventilate a patient, administer oxygen, deliver a volatile anesthetic, infuse a medication through an IV catheter, or manage a patient's temperature, we are applying principles of physics. Think about your experience in the ICU. Why does increasing the diameter of an IV catheter dramatically increase fluid flow? Why does airway pressure increase when bronchospasm develops? Why does a gas-filled space expand as atmospheric pressure decreases? Why can a small endotracheal tube create significantly greater resistance to airflow? And why do patients become hypothermic so easily under general anesthesia? The answers to these questions are found in physics. The goal of this lecture is not to turn you into a physicist. Instead, the goal is to introduce several fundamental principles that you will repeatedly encounter throughout anesthesia education and clinical practice. We will focus on four major areas: gas laws, fluid dynamics, pressure ventilation, and temperature regulation. We will also briefly examine several historical figures whose discovery helped shape modern anesthesia. So, let's begin with gases. Anesthesia providers work with gases every day. Oxygen, nitrous oxide, medical air, and volatile anesthetic vapors are delivered through systems governed by predictable physical laws. Understanding these laws allows us to predict how gases behave when pressure, volume, and temperature change. Boyle's law, the first principle that we'll talk about. Boyle's law states that at a constant temperature, pressure and volume are inversely related. So, in simple terms, as volume decreases, pressure increases. And as volume increases, pressure decreases. Imagine holding a sealed syringe filled with air. If you cover the opening and push the plunger inward, the volume available to the gas decreases. Because the gas molecules are now compressed into a smaller space, pressure increases. If you pull the plunger outward, volume increases and pressure decreases. This relationship becomes clinically important whenever gases are trapped inside the body. Consider a patient with a pneumothorax. Changes in the volume and pressure of trapped gas can have significant physiological consequences. Boyle's law also helps us understand ventilation, breathing circuits, reservoir breaks, and changes in gas-filled spaces. The key relationship to remember is simple: pressure up, volume down. Volume up, pressure down. Next is Charles' law. Charles' law states that the volume of a gas is directly proportional to its absolute temperature when pressure remains constant. In simpler terms, as a gas becomes warmer, it expands. As it becomes cooler, its volume decreases. This principle helps explain why temperature matters when gases are stored, transported, and delivered. Although anesthesia machines are designed to regulate gas delivery precisely, understanding the relationship between temperature and gas volume provides an important foundation for later discussions involving gas storage and anesthetic equipment. The key concept is temperature up, volume up. Now, let's discuss Dalton's law of partial pressures. Dalton's law states that the total pressure of a gas mixture is equal to the sum of the partial pressures of each individual gas within that mixture. The air around us is not a single gas. It's a mixture of gases, primarily nitrogen and oxygen, with smaller amounts of other gases. Each gas contributes its own partial pressure to the total atmospheric pressure. This becomes extremely important in anesthesia because we frequently administer mixtures of gases. A patient may receive oxygen, medical air, nitrous oxide, and volatile anesthetic vapor. Each component contributes to the total pressure of the mixture. A useful way to think about Dalton's law is to imagine several people pushing against the same door. Each person contributes part of the total force. Similarly, each gas contributes part of the total pressure. This concept becomes especially important when studying oxygenation alveolar gas composition, and the uptake and distribution of anesthetic gases. The final gas law in this introduction is Henry's law. Henry's law states that the amount of gas that dissolves in a liquid is proportional to the partial pressure of that gas above the liquid, assuming temperature remains constant. This principle helps explain how gases move into blood. In the lungs, anesthetic gases cross the alveolar capillary membrane and dissolve in blood. The partial pressure of the anesthetic gas influences this process. Henry's law also provides a foundation for understanding concepts that you will encounter later, including blood gas solubility and the uptake and distribution of inhaled anesthetics. For now, remember this basic idea. Greater partial pressure can drive more gas into solution. Now, let's move from gases to fluids. Fluid dynamics is the study of how liquids and gases move. This is highly relevant to anesthesia. We administer crystalloid, blood products, vasopressors, induction agents, and emergency medications through tubing and catheters. At the same time, we manage airflow through breathing circuits, endotracheal tubes, and the patient's airways. Three important concepts are laminar versus turbulent flow, Poissier's law, and the Bernoulli principle. First, let's compare laminar flow and turbulent flow. During laminar flow, fluid particles move in smooth, parallel layers. Imagine cars moving smoothly down several lanes of an empty highway. Everyone is moving in the same direction with minimal disruption. Turbulent flow is different. In turbulent flow, movement becomes chaotic with swirling currents and disruption of the normal flow pattern. Think about the same highway during a major traffic disruption. Cars are braking, changing lanes, and interfering with one another. In the respiratory system, airflow can transition between laminar and turbulent patterns. Turbulence becomes more likely when flow velocity increases, when the airway narrows or changes direction, and when the properties of the gas change. This is one reason airway anatomy and endotracheal tube characteristics can have major effects on resistance and ventilation. Next is one of the most clinically important concepts in fluid dynamics, and I apologize, it's a very difficult word to pronounce that I struggle with. Poissier's law. You do not need to memorize the entire equation right now. You do need to understand one major concept. Radius matters enormously. According to Poissier's relationship, resistance to laminar flow is inversely proportional to the fourth power of the radius. So that means a relatively small decrease in radius can produce a dramatic increase in resistance. Think about IV access. If a patient is rapidly hemorrhaging, would you rather have a long, narrow catheter or a short, large bore catheter? The short, large bore catheter. Why? Because flow is strongly influenced by the internal radius of the catheter as well as its length. The same general concept helps us understand why narrowing of an airway can dramatically increase resistance. When a patient develops bronchospasm, the airway radius decreases. Even a relatively small reduction in airway diameter can significantly affect airflow. The clinical lesson is simple. Small changes in radius can produce very large changes in resistance and flow. Next, the Bernoulli principle. The Bernoulli principle describes the relationship between the velocity of a moving fluid and its pressure. As fluid velocity increases through a narrowed region, lateral pressure decreases. This pressure difference can be used to entrain another fluid or gas into the moving stream. This principle contributes to the function of devices such as Venturi systems. You will encounter these principles repeatedly as you study oxygen delivery devices, anesthesia equipment, and airway management. Now, let's connect physics directly to mechanical ventilation. During general anesthesia, patients commonly receive positive pressure ventilation. Instead of generating negative intrathoracic pressure through spontaneous breathing, pressure is applied to move gas into the lungs. Two major concepts influence the pressure required to deliver a breath: compliance and resistance. Compliance describes how easily the lungs and chest wall expand. A patient with decreased pulmonary compliance requires greater pressure to achieve the same volume. Resistance describes opposition to airflow. Resistance can increase because of bronchospasm, secretions, a kinked ET tube, a small ET tube, or obstruction within the breathing system. This is where physics becomes immediately clinical. If airway pressure suddenly increases during anesthesia, the provider must determine why. Is the problem related to increased airway resistance? Has compliance decreased? Is the tube kinked? Is the patient developing bronchospasm? Has a pneumothorax occurred? Understanding the relationship between pressure, volume, compliance, and resistance allows anesthesia providers to interpret changes in ventilation and respond appropriately. Physics also helps us understand temperature management. Patients under anesthesia are vulnerable to hypothermia. The operating environment is often cold. The patient may be exposed for surgery. Cold IV fluids may be administered. Most importantly, general anesthesia alters normal thermoregulatory responses and promotes redistribution of body heat. Heat can be transferred through several mechanisms. Conduction is heat transfer through direct physical contact. For example, heat may move from the patient to a colder operating room table or surface. Convection occurs when moving air carries heat away from the body. Air currents in the operating room can contribute to heat loss. Radiation is heat transfer through electromagnetic energy between surfaces without direct contact. A significant amount of heat loss in the operating room can occur through radiation. There is also evaporation, where heat is lost as liquid becomes vapor, including from exposed surgical surfaces. Why does this matter? Perioperative hypothermia can affect coagulation, drug metabolism, recovery, and patient comfort. Anesthesia providers therefore use active warming systems, warmed fluids when appropriate, temperature monitoring, and other strategies to maintain normothermia. Temperature management is not simply about making the patient comfortable. It's an important concept of physiological management. The anesthesia machine is another excellent example of applied physics. Medical gases may enter the anesthesia workstation from pipelines or high-pressure cylinders. These gases must be regulated before they can be safely delivered to the patient. Anesthesia workstations use pressure regulators, valves, flow control systems, and pressure relief mechanisms to control gas movement and reduce the risk of excessive pressure reaching the breathing system. As you progress through anesthesia education, you will study the anesthesia machine in much greater detail. For now, understand this. The anesthesia machine is fundamentally a pressure management and gas delivery system. Understanding pressure relationships is essential for both normal operation and troubleshooting. The relationship between physics, chemistry, and anesthesia developed over centuries. And so, we'll provide you a brief history of physics and anesthesia. In the 18th century, Joseph Priestley conducted experiments with gases and independently discovered oxygen in 1774. Soon afterward, Humphrey Davy investigated nitrous oxide and recognized its analgesic properties, even suggesting its potential use during surgical procedures. And then in 1846, William T.G. Morton participated in the famous public demonstration of ether anesthesia at Massachusetts General Hospital. This event became a landmark moment in the development of modern surgical anesthesia. And if you're going to the AANA conference, annual Congress conference this year in Boston, I highly suggest going to check this place out and visiting it. John Snow later advanced the scientific administration of inhaled anesthetics. He carefully studied the delivery and concentration of ether and chloroform, helping move anesthesia toward a more controlled and scientific practice. In the 20th century, Arthur Goodell described the stages and planes of ether anesthesia, helping clinicians understand the relationship between anesthetic depth and observable physiologic signs. These individuals worked during very different periods. but their contributions shared a common theme. The safe administration of anesthesia requires an understanding of how gases, pressure, concentration, and the human body interact. Let's finish by connecting these principles to a single clinical scenario. Imagine you're caring for a patient under general anesthesia. Oxygen and anesthetic gas move through the anesthesia machine according to principles of pressure and gas behavior. The gases combine in mixtures governed by partial pressures. The anesthetic moves from the alveoli into the blood according to principles involving partial pressure and solubility. The ventilator generates pressure to deliver a tidal volume. Airway resistance changes depending on airway diameter and flow characteristics. IV fluids and medications move through catheters according to the principles of flow, resistance, radius, viscosity, pressure, and catheter length. At the same time, the patient continuously loses heat through radiation, convection, conduction, and evaporation. That is physics in anesthesia. It is happening simultaneously, continuously, and often invisibly. And I implore you to listen back to that and try to identify which gas laws are connected to each of those scenarios and examples of each scenario within. As you continue your anesthesia education, these concepts will become increasingly detailed. You will learn equations, calculations, equipment applications, and clinical scenarios. But always remember the larger purpose. Physics helps us predict what will happen before it happens. It helps us understand why airway pressure changes, why gases expand, why flow decreases, why resistance increases, why patients lose heat, and why anesthesia equipment behaves the way it does. Understanding these principles is not about memorizing equations for an examination. It is about developing the scientific foundation needed to think like an anesthesia provider. In the next lessons, we will build upon these concepts and examine how the laws of physics directly influence anesthesia equipment, ventilation, gas delivery, fluid administration, and patient safety. Thank you for joining us, and we look forward to seeing you in the next lessons.